Hi, everyone. Hello, hello. Thank you for logging on early. Please stay put. We'll start promptly at 3 o'clock or in 2 minutes. Hi, everyone. Starting in just a minute. Hello, everyone. Hi, Rhonda. Thank you for logging in early. Please enjoy this rainy jazz music until then. Thank you, Albert. Hello, hello. All right, we'll get started in about 30 seconds. Thank you, Tasha. All right, in about 10 seconds. All right, let's get started. Hi, everyone. Thank you for joining us today. So today's webinar is about incorporating SDOH data into risk stratification models to improve health equity. So before we get started, if anyone is unfamiliar with Zoom, first things first, if you want to unmute yourself and speak, please press the raise hand button in the middle bottom button, and then we can unmute you on your behalf. And then throughout the webinar, if you just want to chat, make any comments, please feel free to put it in the chat box. Also, if you press the blue pill under all panelists and attendees, you can message directly to certain people, and this will be really helpful if you're having any technical issues. And then there's going to be also a separate Q&A box, and we're going to have a Q&A section at the end of the webinar. So to ensure that your questions will be answered, please put your questions in this specific Q&A box, but feel free to put any general comments in the chat box. And then on the bottom right-hand corner, if you need to leave the meeting, please just press that button. And then it will prompt you to take a post-webinar survey. And to continue to ensure improving our training and technical assistance material, we highly, highly recommend that you take this survey. And if you have before, again, thank you so much. And your moderators today is me. My name is Sakura Miyazaki. I am the Program Manager of Training and Technical Assistance, and my fabulous co-moderator, Albert Asen Jr. Albert will mostly be in the background, but he will be helping you with any technical issues. So please feel free to directly message him if you have any issues. And he'll be very active in the chat box, so keep an eye on the chat box as well. And we are both a part of the Association of Asian Pacific Community Health Organization, or AAPCHO for short. And AAPCHO is dedicated to promoting advocacy, collaboration, and leadership that improves the health status and access of Asian Americans, Native Hawaiians, and Pacific Islanders within the United States, the US territories, and the freely associated states. So our two presenters today, first is from AAPCHO, Vivian. So Vivian Lee is the Research Project Manager / Analyst at AAPCHO. Vivian manages the quantitative and qualitative research activities across AAPCHO's projects, including supporting the communication of research findings as analyses and models in the organization's publications and reports. Vivian's research areas include enabling services and social determinants of health, and is a member of the National Prepare Team. Vivian received a Bachelor of Arts degrees in mathematics with a concentration in statistics from St. Olaf College and a Master's of Science degree in mathematical statistics from Purdue University. And then following Vivian's presentation would be Dr. Armston. And Dr. Armston is a passionate scholar practitioner in the field of health psychology and clinical psychopharmacology. He received his doctorate in clinical psychology from the Illinois School of Professional Psychology at Argosy University and completed his clinical psychology internship at Aurora Behavioral Health Services, Aurora Sinai Medical Center, and St. Luke's Medical Center in Milwaukee, Wisconsin. Dr. Armstrong obtained his postdoctoral Master's of Science degree in clinical psychopharmacology in 2017 from the California School of Professional Psychology at Alliant International University. Dr. Armstrong taught and served as an adjunct faculty at the Chicago School of Professional Psychology and Roosevelt University, and his leadership roles include the Chief Clinical Officer. Currently, Dr. Armstrong is the Director of Behavioral Health Services at Community Health Net Health Centers in Gary, Indiana. And Dr. Armstrong is recognized on the local, state, and national level as an expert in primary care and behavioral health integration in assessing social determinants of health factors impacting patient health outcomes. So again, thank you so much, Vivian and Dr. Armstrong, and we are so looking forward to your fabulous presentation about SDOH factors. Okay, now that we introduced ourselves, Albert, if you could release the poll for organization type, we would love to know who is in the room today. So the question is, which of the following best describes your organization type? Are you a community health center, a primary care association, a national training and technical assistant partner, a health center control network, government, academic institution, social service, or community-based organization, or other? And if you are other, also feel free to put it in the chat. We would love to know who's in the room today. And let's give about 20 more seconds, Albert.
Great, yep, 20 more seconds, and we're seeing about a third of you are health centers, which is great. 15% are PCAs or primary care associations, and then we got some government and other that are also trailing. So fantastic. Thanks for joining.
Yes. I see people in the comments as well: health plan, EHR trainer, healthcare system, insurance company, lots of different types of people in the room today. So thank you so much for joining us. All right, I think we can close the chat now. Great. So moving forward, our learning objectives today are 3 main objectives. So first is to understand the importance of using social risk factor data to improve population health at health centers. And population health in this instance, we're defining as the health outcomes of a group of individuals, including the distribution of such outcomes within the group. And then the second learning objective is to incorporate takeaways from a national protocol for responding to and assessing patients' assets, risks, and experiences. So prepare for short, risk stratification models vetted by health centers, primary care associations, and health center control networks. And then with Dr. Armstrong, we're going to learn from a health center example, leveraging social risk data to identify and address individual patient needs. So based on that, we're going to, with Vivian, have an introduction to risk stratification, and then Dr. Armstrong will be presenting on behalf of Community Health Net Health Centers, and then we're going to close with the Q&A. So please, Vivian, take it away.
All right, thank you, Sakura. So I wanted to start out by defining risk stratification, as it is often confused with risk adjustment. Risk stratification is a process or tool for identifying and predicting which patients are at high risk for care management, whereas risk adjustment is a method for offset the cost of providing health insurance for individuals who represent a relatively high risk to insurers, and therefore it's typically used at the policy or payment level. Next slide, please. So this picture represents risk stratification as it separates high risk patients from the other levels of risk. So for example, Joe has certain risk characteristics that put him in a very high risk group, whereas Jen is at a lower risk based on her characteristics. Clinics and health centers use risk stratification to help them identify the right level of care and services for different patient risk groups so that they can maximize efficiency, improve outcomes, and deliver value. So overall risk stratification is used to identify high risk, high cost patients, understand why they're high risk, and coordinate interventions to appropriately care for these patients. In addition, clinics and health centers conduct risk stratification to better inform staffing and how to allocate resources and manage panel sizes to be able to provide better care for patients. Next slide, please. And then why are people interested in risk stratification? Because literature shows that a very small portion of the population accounts for half the cost. So if we can help address care for these patients, we can presumably reduce cost as well as improve health equity by addressing the needs for the most complex patients. Next slide, please. Risk stratification that particularly incorporates SDOH is also important in positioning health centers for sustainability, especially as health centers are held accountable for their outcomes. This shift in value-based payment and greater demands for evidence. We also know that traditional risk stratification models have emphasized on clinical conditions and downplay the impact from patients' SDOH barriers, and therefore do not have optimal performances for predicting complex patient population that health centers serve. The growing competition and need to build an evidence base are the reasons why we need all health centers engaged in a data strategy that demonstrate value. PCAs across the nation are actually starting to use this data to advocate as well. This environment, combined with the growing emphasis on SDOH, has spurred a need for tools and tools to stratify patients by social risks to address these risks and to document patient complexity and demonstrate value. So this is where Prepare plays an important role. Before I briefly introduce Prepare, I'd like to actually launch a poll question. I'm curious, do you currently use Prepare at your organization to screen for patients' SDOH needs?
And just in case, the poll is now launched for you all, and we'll give it another 30 seconds. And we're seeing about 50% are doing, screening for Prepare, and 28% are not, and then others are planning to. And then others don't know what Prepare is, Vivian. So I'm going to close the
this
poll.
is great. Thank you. So I'll briefly introduce Prepare. Prepare is a collaboration between NAC, AAPCHO, and OPCA and other health center stakeholders. Prepare stands for the Protocol for Responding to and Assessing Patients' Assets, Risk, and Experiences. And Prepare is a nationally recognized and standardized patient risk assessment protocol that accounts for patients' SDOH and is the leading social risk screening tool used by health centers and Medicaid managed care organizations. Actually, according to the 2019 UDS data, about half of the health centers that used an SDOH screening tool were using Prepare. Prepare was designed to engage patients in assessing and addressing SDOH. Prepare is evidence-based and stakeholder-driven, containing measures on 21 different SDOH factors that align with national initiatives such as the IOM recommendations and maps to other coding systems, including the ICD-10 code, SNOMED, and LOINC. And Prepare has been translated into 26 different languages. And Prepare includes 17 core and 4 optional questions. So I won't really go into the details about Prepare today, but there are many resources available on the Prepare website if you'd like to learn more, including a 10-chapter implementation and action toolkit. And we have other fact sheets and webinar recordings on the website as well. And also, please feel free to reach out to me or to the Prepare team for any questions. Next slide, please. So as we were finding that many health centers and some state PCAs were already using Prepare in risk stratification, we launched a Prepare Risk Stratification Learning Collaborative in the summer of 2019 to improve our understanding of organizations' best practices and lessons learned, as well as how organizations apply and use Prepare Risk Stratification within their clinical settings. We also explored the development of a common national standardized risk stratification model with options for localized methodologies, building off the participants' existing strategies. We saw this as an important process to incorporate the community voice for community stakeholders to weigh in on what is most important in predicting risk for their patients as community health centers serve the most underserved and complex patients in the nation. Next slide. Yeah, there's one. Yeah, okay, thank you. So then overall, the outcome of the learning collaborative were to develop a core national standardized risk stratification model with optional measures and methods that can be tested with Prepare SDOH data, and publications on best practices and lessons learned, as well as a plan to test the predictive validity and the clinical utility of the risk stratification model incorporating the Prepare SDOH data. Next slide, please. The learning collaborative participants emphasized the principles that are listed on this slide. So first, we intended for the risk stratification model to inform but not replace clinical care judgment. In addition, we did not want social risk stratification to replace social risk screening. In fact, social risk screening is a precursor for this risk stratification modeling. And the participants wanted to make sure we develop a national standardized numeric score that can be used for comparison, important for policy and payment implications. We also emphasize the need for the local clinics to decide on the risk group cutoffs based on their own clinic or community resources. And in the algorithm and the visualization, the participants also wanted the 4 components of the model to be organized in categories to better understand aspects of each component for each patient to target appropriate care. We wanted a simple point system to be used at the point of care with a higher score representing a higher risk patient. And finally, the participants recognized the importance of being able to test and validate the risk model. Next slide, please. So here is the model as a whole, and I know there's a lot of text on this slide, but basically the model's target population is the general population of adult patients. And the top risk stratification goals are to identify complex patients to facilitate appropriate interventions primarily for clinical use, and also to demonstrate the complexity of patients for policy purpose. And overall, this stakeholder vetted risk stratification model includes 4 components: clinical, behavioral health, social determinant of health data as informed by Prepare, and utilization. The risk stratification groupings we developed were classified as urgent need, high need, moderate need, and low need. And finally, we also discussed the recommendations for resources that should be provided to different risk groups, which we'll have a start on, but we'll be working on more in the future. Next slide, please. So the model, this is a graphical representation of the risk stratification model. includes 4 components, as I mentioned before, defined by measures in each of these 4 components. There are 7 measures in the clinical component, 7 measures in the mental health and substance abuse component. The Learning Collaborative preferred to focus on the SDOH component and identified 7 clusters of SDOH based in part on our past SDOH cluster analysis we conducted using prepared data. We also recently did some analyses that supported our SDOH scoring, although we acknowledge that there is much more validation and analysis to do. And finally, the utilization domain include both emergency department visits and inpatient hospital stays. In terms of weighting of the different components, the Learning Collaborative decided that the SDOH category should have the most weight, double the weight of the other categories. Next slide, please. So to summarize, here is the process for risk stratification and segmentation into groups. First, compile data from active patients, and then assign a score for each data component using the most recent patient data. Then combine and calculate total risk scores for each data component for each patient. Sort by total risk score and stratify patients into risk groups. And then an important step here is for the clinic team to come together to huddle and validate the risk groups. From there, target interventions based on the risk groups and use standardized total risk score for national comparison with other similar organizations. The purpose is to make the highest risk patients more easily visible for clinic team to prioritize and address their needs. Next slide, please. But there is not actually enough widespread data collection to do so. At AAPCHO, we have already developed a protocol to document enabling services, and I wanted to share it with you in case you have not seen this data collection resources. It's available on our website, including a data collection handbook, protocol, and implementation packet. All of these are also available in chapter 10 of the Prepare toolkit that you can find on the Prepare website. Similar to Prepare, we developed these resources in partnership with a variety of community and clinic stakeholders and national partners. And once we have this enabling services social intervention data, this could also be included in the risk stratification model as well. Next slide, please. So how should we use the national model? The Learning Collaborative participants provided some insights that are listed on this slide. Sorry, I have some renovation going on in my house. Sorry for the background noise. So first, improve care management and interventions, which includes meet the needs of patients in various risk tiers, prioritize and address care management needs that can ensure high quality and timely care. Second, standardization and the national comparison. The participants commented that they appreciate having a standard format to compare with others nationally, and the use of a universal framework with national aggregated data will allow great knowledge sharing and communication. Third is demonstrate complexity of patients, and this is to help illustrate the complexity of health center patients' conditions. And fourth, inform value-based care and cost savings. For this use, the participants commented the model could prepare them nationally for value-based payments and decrease total cost of care and improve outcomes for patients by focusing efforts on highest utilizers. Fifth is qualify for PCMH and quality incentives, and outside of the clinics to inform payment and policy. Specifically, the participants said inform risk adjustment of social factors that will be key to payment and delivery reform on the state level. Last but not least, we have also heard from partners who are using risk stratification, especially in this time of COVID, to prioritize patients they need to outreach to address SDOH barriers. Next slide, please. So speaking of COVID, in May 2020, we conducted a survey on how health centers are using Prepare during the pandemic and came out with a fact sheet that which outlines how Prepare SDOH domains impact individuals' risk of morbidity and mortality from COVID-19. You can find this fact sheet on the Prepare website. We're actually conducting a follow-up survey to check in on how health centers are using Prepare now that we're a year into the pandemic. Next slide, please. Our next steps include future pilot testing of risk stratification model. Some of our risk stratification learning collaborative members already expressed interest in doing this, so we're now planning for the pilot testing. And at the same time, we are working with a wider Prepare national analysis strategy with the plan to test the nationally developed risk stratification model with larger scale patient level data set. We're working on some publications on best practices and lessons learned, as well as developing resources to help with the risk stratification model implementation, such as workflow use case scenarios, intervention recommendations for different risk groups, and visualization examples. Working with a panel of experts as well as the stakeholders from different levels of healthcare, we are also developing a Prepare social intervention codes so that how the Prepare social risks are addressed can be documented and we can close the loop there. We also have a fact sheet on this work, our risk stratification work that will be published in the April Prepare newsletter. So please stay tuned for that as well. Thank you. Now I'll hand it back to Sakura.
Thank you so much, Vivienne. And yes, Dr. Armstrong, please take it away. Oop, you're muted, Dr. Armstrong.
Thanks, Akira. First of all, I would like to say thank you to Albert for reaching out to me a couple of weeks ago to be a part of this discussion and presentation, and also for spotlighting Community Health Net health centers and the important work that we're doing on risk stratification and our chronic disease management. Next slide. So at the top left-hand corner, this is one of our 6 clinics of Community Health Net, and it's one of our newer clinics. So we're really excited about that. This slide really looks at a timeline. We first began doing the work of introducing social determinants of health into the workflow of screening all of our patients in 2016. So we really at that point found that to be some very exciting work. The discussion actually started from a provider meeting that I had attended, and the conversation went something like this: patients aren't getting better. Why are they getting in the way of their health outcomes? And part of me scratched my head because I said, I wonder, how true this is. Do patients really not want to get better in terms of their diseases? And that just didn't resonate with me. And then our computer person approached me and said, I just found this really great tool, and it was the Prepare tool. And when we began to implement that tool and begin to have conversations with patients because they had identified some of the factors on that tool, we found that patients really wanted to have better control over their health, but there were certain things that got in the way, such as not being able to afford the insurance, not being able to buy the healthy foods that their doctor was wanting them to eat, not being able to be in a safe neighborhood where they could exercise and so forth. So the value of the Prepare tool became a very important tool for us in terms of identifying barriers that prevented patients from having better health outcomes. The 2019 was very important because Community Health Net was invited to be a part of the Risk Stratification Learning Collaborative. And it was a very exciting time. And I left that training, it was in San Diego, and came back to Community Health Net really excited and charged about the work that we had done over a 2-day period. So this slide really shows that Community Health Net has been doing social determinants of health for a while now. Next slide. So the rationale for why Community Health Net is invested in using risk stratification and the inclusion of social determinants of health in predicting our at-risk patients. Definitely with aging of the population and an increase in healthcare expenditures, nationally there is recognition that there needs to be improvement in care, but also being able to keep care down. Uh, Also, the different models looked at optimizing healthcare organizations to address the complex patients that we deal with. So, I mean, not only are we looking at the physical health, but we're also looking at the mental health of our patients, patients that have substance use disorders, and on top of that, including how the social environment impacts on their health and their health outcomes. Next is refining traditional methods to determine what level of risk a patient is for utilizing the present and near future as a core way to strategize our targets. So definitely we wanted to figure out, instead of spreading interventions across all populations, which could be time consuming, but could be very costly, again, targeting that level based on the pyramid that Vivian showed, the patients at that top, really focusing on those patients and allocating resources and targeted interventions to see if we can bring about change in their healthcare outcomes. But not only that, what we were really looking at also was the frequencies to emergency room departments and also increased numbers of inpatient hospitalizations. Next, historically. Sometimes when you are involved in some stuff and you're not really doing the work just yet, because I remember back in 2000, maybe 17, even though we had started looking at social factors and how it impacts healthcare, it didn't rain on me that we were being introduced by the state to look at risk stratifications. And during that time, we looked more at claim denials. We looked at the frequency of emergency room visits. We looked at the number of medications that a patient was on and diagnosis. And all of a sudden, an aha moment happened for me that really what we were talking about was risk stratification. And it wasn't until, like I said, that learning collaborative, that the work that we were doing with social determinants of health just became another factor that we could include into that model that really helped us to identify those high-risk patients. There are clinical and administrative values to incorporating social determinants of health measures into risk stratifications. And again, that becomes identifying your high risk patients, but also allocating resources and interventions specifically to that group. Next slide. So this slide is very exciting to me. As exciting as a provider that is working in an integrated care setting, because in a primary care setting, we look at the genetics, what a person is born with. We look at the impact of the health organization. But a big factor in terms of the impact of different factors on risk for premature deaths really has a lot to do with a person's behaviors, health behaviors, but also that social and environmental factor. So this really drove home the importance of not only looking at patients through a single lens, but expanding our conception of a patient through different lenses to include the whole person, the biology, the psychological, including health behaviors, but also how that person's environment can shape their health outcomes. So really important slide. Next slide. So what was the specific aim of Community Health Net when we set out to do this work of risk stratification, incorporating social determinants of health? The first aim was, how does high risk status defined using traditional predictive risk models? And those models, like I spoke to, included such things as claim data information. It looked at biometrics, a person's lab values, their vitals. It looked at diagnosis. It looked at the number and the amounts of medications that a person was taking. How did that compare to using a model that incorporated social determinant of health patient screenings? The second aim was to, does the incorporation of social determinants of health improve predictive power of risk adjustment? The third aim, to what extent does social determinant of health measures from patient screening questionnaires and traditional data source predict risk-adjusted hospital admission rates, emergency room utilizations, and clinical characteristics? So the different disease states that a person could be in. Next slide. So I wanted to share with you the method that we went through. So Community Health Net was awarded a grant, the PIP-BHC grant, which is a promotion of primary behavioral health care, back in 2018. And we were awarded this grant through the state of Indiana, and we were one of 3 recipients to receive the funding. So the work that we did looked at patients who had high blood pressure, diabetes, and or issues with cholesterol, on top of having a behavioral health condition. So from 2018 to September of 2020, we had enrolled 337 patients into this study. When I was approached by Albert and I thought about the time to sort of like look at the data that we had collected on patients, I was like, 337 is too big of a number to try to make sense out of right now, as we're still working with the state and SAMHSA to look at those variables for results. So what we did was we broke the 337 down to 30 patients. And out of that 30 patients, we had 20 valid cases. Now, what is a valid case? Valid case is from baseline, so enrollment into the study, to patients that we were able to collect information on for 3 months to almost 2 years. That was dependent on how long a person stayed enrolled in the study. So that's how we got that number. So we're looking at a sample size of about 20 out of 337. what we did was we looked at patients, their biometric values. When they did their labs, was it within normal range or was it outside of those normal values? We looked at the diagnosis in the chart. We looked at the patient having a mental health condition and or substance use disorder. And then we incorporated the information from the prepare screening to collect information. And from that, we group patients into either a high, medium, or a low category. Next slide. So in terms of the demographics of just the 20 patients that I mentioned, 80% of those patients are female and 20% are male. The majority are African American, and we had two participants enrolled in the study that are Caucasian. Next slide. So community health net population group by age. The largest of the population are persons that are 18 to 44 years old, followed by persons that are 45 to 64. And then we had a small percentage that were 65 and older. When we ask through the national outcomes measure, which is through SAMHSA, did patients feel like, or participants feel like they had enough money? We found out that about 60% of our participants said that not at all or a little. So that's a big deal, especially when we're looking at a patient population that may have several medical conditions in addition to possibly a behavioral health condition. And we have those patients who have to make lifestyle changes, but also who may have to purchase medications or copay for medications. The thought of not having enough money or a little money, definitely we can see how it impacts some decision making when it comes to managing one's person's health. Next slide. So the results of the intervention. What we found out is that we were able to get with the classifying patients and then allocating resources and providing strategic interventions, that we were able to bring combined blood pressure down. So we saw improvement there. We also saw improvement in being able to see impact in the person's LDL cholesterol, which is that bad cholesterol. So definitely there was impact. We didn't see any change with a person's BMI and then the hemoglobin A1C. I had a chance to really talk to one of our medical providers, and I was discussing the results with that provider, and intuitively to me, but then she confirmed it, is that with medications, we may see more of a change. Definitely patients being adherent to the treatment, following up for visits, that we would see those changes with possibly blood pressure and cholesterol. However, with weight and with diabetes care and management, that requires a little bit more lifestyle changes. And I'll talk about it in a later slide, the thought that I think may have impacted those numbers. So next slide. So, but some hopeful information. Here is service outcome measures. Now you may say there are no numbers there. And the thing is that as an organization with SAMHSA, who our information is housed with, they have the three organizations that's a part of this grant information lumped together. So we're working with the state of Indiana to figure out how to tease out our information from the other two organizations. So That's why this graph is incomplete. We're still working with the state so that we're able to get numbers that will really show us how effective the services are that we're providing. That we look at overall health, we look at homelessness, we look at hospitalizations for behavioral health, but also physical health reasons. And we also look at the utilization of the emergency department. Next slide. So strategies for implementation. And I think there's a poll that we were going to do here.
Yep, Dr. Armstrong, I will launch that poll for you. And let's see. All right, the poll should be launched now. And just asking everyone, which one of the following strategies are you most invested in for your health center organization? And we're just asking you to choose one top of mind. We're getting a lot of responses at the moment, and it's looking like a good distribution across the different responses. So very much all are important strategies that all are invested in. So I'll give it another 10 seconds and I'll share the results. All right, closing the poll.
Great. The fact that about 50% of you with the earlier poll stated that you are looking at addressing social determinants of health factors with your patient population, that's the important work in the beginning of the work right there. Definitely as you get more into the work and you look at the risk stratification, the more that you're able to have buy-in from everyone involved in patient care and the collaboration, the better. The other thing that we find out is allocating resources to those patients at high risk, but definitely continuing to assess, and as you saw in the two previous slides, if patients are getting better, that we no longer keep them maybe in that high risk range, but we lower them down to other risk levels, such as moderate or low. Therefore, we can spend more time on those other patients who are just finding out that they may have a chronic health condition, or that they've had a chronic health condition and they aren't getting better but are getting worse, that we can open that up for those patients. So definitely reassessing patients' risk levels. Being able to have the risk levels visibly in the EHR so that all people involved in the patient's care can see that, and also be able to adjust the risk is important. Next slide. So support for patients with chronic illness. And this is the role that I see and where Community Health Net is really moving forward with utilizing certified community health workers. Definitely stuff such as helping patients problem solve, we're doing it, being providing emotional support, encouraging follow-up, encouraging participation from patients, acting as a liaison between the patient and the provider, connecting patients with resources, facilitating support, being a familiar face. That's really important to patients. Sometimes they don't see their provider nothing but maybe once every 2-3 months. So to be able to have a familiar face that is there to be supportive, to also to coach that person or cheer that person on is really important. The thing that I like about the image at the top right hand is sometimes having a chronic health condition is almost like being on a mountain, and that mountain can be very hard to navigate at times. And at least here, having the community health worker, there is that support there. I spoke with my CEO, Dr. Janet Seabrook, a few days ago as we were going over the presentation, and she noticed something that I didn't catch on to right away. And she says, not only does a community health worker it is there on that mountain with the person, but they're also anchored. And we see that person with the anchor in their hand. So the patient feels comfortable, feel confident, and they feel safe with that community health worker. The things that I did highlight and the area where we as an organization are moving with our community health workers is the community health worker being able to be comfortable. Some are, some aren't as comfortable to provide health information to the patient on their disease, to be able to work with the patient on self-management goals that they and their provider, whether it's their medical provider and or their behavioral health provider, have initiated. Next slide. So limitations so far that we have encountered. One of the limitations may be is that we focus mostly on chronic disease and definitely patients who have behavioral health and or substance use disorders. This could possibly look different in just a true medical patient population. The next thing is individuals could misrepresent their social determinants of health needs. Now, there's two factors that stand out. One is that there is very sensitive information that we ask patients. So sometimes they may not report the true area of need due to the question. But the other thing in the beginning around 2018 is that we were patients that had needs, definitely things such as housing, food, clothing, those types of things. We as an organization, through the grant that we received, were helping patients out. So sometimes patients may have over-reported just to get that additional assistance. The next thing in terms of the limit is, again, being able to work with the state of Indiana to figure out how SAMHSA is doing their calculations so that we can get our own data or information to see how our services are really impacting things such as health outcomes, admissions rate to the hospital, and emergency room utilization. One other thing that I found, and this was something that I noticed when we had started looking at depression screening in our patients, whereas providers, medical assistants may have, with the depression screen, not screen older adults because they didn't think those patients were at risk. What I found with social determinants health is that sometimes the providers didn't screen our younger patients, maybe with the the assumption that those patients didn't demonstrate need. And what we really find out is that that's a very critical time, especially in a young person's life, especially going from being a teenager to a young adult, graduating high school to either going into the workforce, going to college, possibly leaving parents' home, getting their own housing, is that there may be those social factors that could impact their health if they had a health situation. The other thing that I mentioned, that the BMI and the A1C, those numbers didn't change. I think sometimes this last year with COVID, it really impacted the in-person visits with patients, which probably, and also patients having more of a sedentary lifestyle, depression could have been a factor, which may have affected a patient's lifestyle commitment or choices to assist with managing those disease states. Next slide. In terms of limitations, let me say this: even though the sample size was low, 20 people, I still feel very confident that using the risk stratification and including social factors is very strong in predicting high-risk patients. But again, I think there is the benefit that we're able to measure how our interventions are. So I'm really excited about that. Due to time's sake, here what we want to do is, as an organization, is move towards a more structured algorithm to determine the patient risk. So before, whereas we looked at certain things and put patients into a category of high, moderate, or low, we want to take it a step further and begin to take that information and put patients into risk levels, and definitely begin to focus more on levels 4 through level 6. Next slide. So the road ahead. One potential focus for the future work is really working with the state so that we're able to get our own specific information that helps us to know how we're doing with the risk stratification model that we have implemented, but also how our allocation of resources and interventions are driving patient care. We want to use this as we deal with patients through the lifespan, a longitudinal care as a longitudinal care management. Definitely, we want to schedule high-risk patients for longer visits, groups, classes. With COVID, optimizing telehealth appointments. The most important thing with this is the important thing with social determinants of health is definitely those patients where transportation may be an issue. The thing that I've really found out is that we can put patients definitely appointments together, medical appointments, behavioral health appointments, community health workers appointments on same days and extend out the visit, that we're taking those things into consideration. We want to prioritize resources so that we're really helping patients out and that we make the risk levels easy to find in the medical record. Next slide. Conclusion, it's definitely a different way of thinking and practicing. And I think when we just focused on biometrics, when we just focused on claims data, that it provided a good predictive way of predicting risk patients. But I think when we added that something extra, it's almost like adding that special ingredients into a recipe. I think when we include social determinants of health, we get way much more richer, valuable information that really lets us know and helps us to target specific interventions so that we can address those things, that we can get changes in the other areas. So really an important tool. And I thank again AAPCHO and I thank AAPCHO for again inviting me and spotlighting the work that Community Health Net is doing in the area of risk stratification and the inclusion of social determinants of health. Thank you.
Thank you so much, Dr. Armstrong. Like, I loved hearing you speak about that aha moment that you had when you were learning about risk stratification and just how you were able to utilize the risk stratification learning collaborative that Vivian discussed to really make this into play, and just working with the state. Like, all of this is just so phenomenal. I've also saw in the comment from Christine that this is really admirable work, something to aspire to. So again, just thank you so much. I know we only have a few minutes left, but there are 2 questions in the chat Q&A box that are still unanswered. So just kind of want to quickly go through them. First is from Tom. Where do you find certification programs for CHWs? Dr. Arnton, if you could answer that.
Certification programs for CHWs. I personally can't tell you. However, our chief strategy officer has a connection through the locally that we send our community health workers to get the training and certification. However, I think also on a state level, there is an organization that the Indiana Community Health Workers Association. That's an organization. So I would say definitely Google to see what resources are available in your state for training and certification.
Great, thank you. And then we have another question from Gabriella. I'm sorry if I missed this, but what percentage of a patient population has a documented prepare screen on an annual basis? Also, how are you measuring the impact or outcome and satisfaction for social interventions and services provided? Thank you for a terrific presentation.
So all of our patients get at least annually a prepare screen. If they are engaged in behavioral health care, and definitely if they're enrolled in this PIPBHC grant, every 3 months they are administered the prepare screen just to see if there's been any changes in their social factors. In terms of looking at the work, it's funny. The work is the data has been there. With this presentation, we just really start looking at it. So when we start really looking at it, we saw the things that would help us to figure out how impactful the interventions are. So that's our next step, is working with the state, working with SAMHSA to kind of assess how we're doing.
Great, thank you so much. And Tom, I also saw in some comments some resources for your certification programs. And since we only have 1 minute left, I just want to close out. And again, thank you, Dr. Armstrong and Vivian, for your fantastic presentation. And after you leave the meeting, you will have an evaluation survey. So we would really appreciate it if you could fill that out. And if you have any outstanding questions, please email us at training@apcho.org. Thank you, everyone.